to the MPT Foundation Endowment provide essential funding for our projects and programs. We thank the E.T. and Robert B. Rockland Fund for its generous support, benefiting all of our diverse communities for years to come.
Direct Connection is made by MPT to serve all of our diverse communities and is made possible by the generous support of our members. Thank you. Live from Maryland Public Television, this is Direct Connection with Jeff Salkin.
Tonight, the COVID comeback, how to stay safe as the virus spreads.
We've got to now stay away from one another in 2020 so that when we meet again in 2021, nobody will be missing.
Who should be tested and how?
A rapid test can give you a very good indication in a relatively short period of time.
Fighting through pandemic fatigue.
It seemed like I do the same thing over and over every single day.
Been trapped in the house with 4 kids and a girlfriend.
Will a vaccine end this national nightmare?
The cavalry is coming. A vaccine is on the way.
Good evening. Welcome to a special edition of Direct Connection. Tonight, we are about 9 months into this global battle with the coronavirus. It is a battle with heavy casualties. Maryland has lost nearly 5,000 citizens. And just as a new and potentially decisive weapon, a vaccine, is arriving to hopefully end this battle, the outbreak is worsening. It is winter. People are indoors where the virus spreads more easily, and our hospitals are again filling up.
It's often said that it's always darkest before dawn. And right now, we do remain in a better position than many other states, with the 8th best positivity rate in the nation, the 9th best case rate, and we are the 4th best mask-wearing state in the nation, with 96.7% compliance. However, in spite of all that success, it is clear that our worst days of this pandemic are still yet to come in the weeks and months ahead.
Tonight, our goal is to make sure you have all of the information you need to keep yourself and your family safe, which is a challenge as battle fatigue sets in. Here's MPT's Nancy Yamada.
Yes, I have COVID fatigue. It seemed like I do the same thing over and over every single day.
9 months into the pandemic, it appears many people are simply over the masks, the restrictions, and a new way of life that's kept people at home and away from work, school, and gatherings with friends and family.
I miss interacting with people. I miss having that conversation, that laughter, that in-person contact.
And then there's being together with the same people day in and day out.
Been trapped in the house with 4 kids and a girlfriend, and nothing really to get the kids out doing, so,
It's hard.
It is very hard.
So are following the rules and daily safety guidelines.
Having to do these extra habits for such a long period of time, and in particular, the distancing from in-person social opportunities is really wearing down on people's resolve to continue it at a very high level.
Dr. Carissa Parrish is an associate professor on faculty at Johns Hopkins University School of Medicine. She says COVID fatigue can impact anyone, from healthcare workers on the front lines to parents, and kids to people who live alone. Not knowing when the pandemic will end might lead to riskier behavior.
The uncertainty of how much longer, and I think a lot of us are like, oh, we're almost there, so can I just stop now? Because we're so close. Can I just get off the hook now?
For others, COVID fatigue has led to physical problems,
Feeling too tired, I don't want to get up, I don't want to go do things.
and emotional issues.
I'm getting grumpy with everybody. My daily activities feel like they're too burdensome.
Dr. Parrish's advice, take it one day at a time. Focus on activities that add to your physical health and psychological well-being.
Reading for fun, that added a little happiness quotient. Me going for a 10-minute walk on my lunch break, that added a little bit. I'd rather see my friend in person, but actually I still like talking to her on the phone. That added a little bit back.
And when it comes to children who miss their friends and classmates,
Provide emotional validation that their sense of loss and sadness, loneliness is completely valid.
And one final tip, if you are feeling overwhelmed or anxious, Dr. Parrish says you may want to avoid hours of just scrolling on your phone.
There's probably a sweet spot of staying informed of what's happening with the vaccines, what's happening with the testing, what's happening, in different geographical areas. And we don't need to be on the phones 8 hours a day monitoring that.
I'm Nancy Yamada for Direct Connection.
Joining us now are Dr. Gregory William Branch, the health officer for Baltimore County, and Dr. Travis Gales, the Montgomery County health officer. Nancy Yamada stays with us as well. Doctors, we appreciate your time. Let's start with some basic advice for people who maybe do have a bit of COVID fatigue at this point and want to have as normal a holiday season as possible. Dr. Branch, what would you advise?
Well, I have to remain and continue to advise about the 3 W's. It's always important to say, wear your face mask, wash your hands, and watch your distance. And I do recognize, and I like to tell people all the time, just because you can doesn't mean you should. So please do the 3 W's and be very, very mindful of that.
Dr. Gales?
I would say that adhering to the guidelines that Dr. Branch has put forth will ensure that it keeps you safe in the meantime now, so that you don't run the risk of coming into contact with someone who is COVID positive and you thereby getting COVID to hamper your ability to be able to be with your family in any way, shape, or form in a couple of weeks.
Mm-hmm.
It's always around this season that everyone is gifting things, especially homemade items. Is that a bad choice this year? Should we be giving our neighbors homemade cookies? Is that a way to spread COVID?
Well, I think
I can say, I'll just jump in and just say, the fact that you actually cook something for someone is not going to spread COVID. I would rather you do that and gift them with that than gift them with a virus. So if that means that we can't get together, that is okay, because I keep telling everyone, we've got to now stay away from one another in 2020 so that when we meet again in 2021, nobody will be missing.
Dr. Gales, how do you feel about the the homemade fruitcake? Is this a good year for that or no?
Well, I think the key is, as Dr. Branch pointed out, is that there are alternatives to what we have historically done. And there are some things that you can put into place in the absence of being able to physically get together. And, as with following those 3 W's, if you are going to exchange different things like, cooked, baked items, making sure that when you do exchange them, you are minimizing your points of contact. You're washing your hands and you're cleaning any other relevant surfaces, and continuing to observe those physical distancing measures as much as possible.
Do I perceive it correctly that the medical profession is now more focused on inhaling virus particles as opposed to touching something and then touching your face and getting it that way? Do we really know? I've used a lot of hand sanitizer in 2020, and I'm wondering if it really is okay to cook food for somebody else. Is it less about hand washing than maybe it was in the beginning? Not that we're telling anybody to not wash their hands, but what's most important right now?
I think at this point now, it's all very, very important. If you're cooking food for somebody, you need to be washing your hands, period, point blank. And that's with COVID or without COVID. You've got to wash your hands. It's very, very important. As we're talking about COVID, yes, we want to wear our masks, but we also want to wash our hands, because if you touch a doorknob that has COVID on it, and then you touch your face, you're basically introducing that COVID into your body. And we do not want you to do that. That's why it's extraordinarily important to continue to wash your hands, but also to wear the face covering.
Packages are going to be flying around. UPS, FedEx, Amazon, they're going to be really busy. I'm curious what you gentlemen do when you get a package in the mail or at your door, do you wash your hands after touching it? Do you quarantine it? How do you personally deal with that?
Well, I always wash my hands because in addition to COVID, it's also flu season and a host of other respiratory conditions that hand washing is important to minimize your risk of contracting whatever those particular issues are. But typically, if I'm lucky and fortunate to get a package, I'll usually just wipe it off with some type of hand wipe and then wash my hands. But beyond that, I don't quarantine packages personally.
Right. And quite frankly, for this holiday season, if one of your viewers wants to send me some oatmeal cookies in a package, I would accept them, and I would just wash my hands after I accepted the package.
Dr. Branch and Dr. Gales, I have a question about masks. When we're outside and we're exercising, for instance, maybe we're walking our dogs, would you recommend that people, given the COVID numbers right now, that we wear our masks? And, you know, maybe we're doing this in an area that's not particularly crowded, but perhaps we run into people from time to time.
I say this, if you're by yourself, you may want to take a mask break. But if you're going to be around anyone else who is not in your household, put your mask on, period.
We have similar guidelines in terms of our county mask mandate, in terms of pretty much if you're going to be around folks, carry it with you, put it on, because right now we've got to use our full complement of tools available to try to get these numbers down, given such high rates of community transmission.
Let me ask both of you, does it matter the type of mask? Tell me the best mask, the best adherence to mask policy that you're seeing just out on the streets, and maybe some mistakes or some inappropriate masks that people are using.
So from overall, basically a face covering is fine. What we say is the fact that it should be snug against your face and covering your nose and your mouth. If you have on a face covering that's doing that, I think you're actually doing very well. Barring, I'm not talking about medical stuff, but just for the regular interaction of what we're doing socially, I think in a face covering that's covering very snug against your face and covering your mouth and your nose. Wearing a face mask underneath your nose is not doing anything for you or for the other individual. You've got to wear it above your nose.
I have a question about, we're going into the winter season. We've always been advised to get a flu shot. I've heard a couple people say, you know what, the kids aren't in school this year. So there's probably not going to be a lot of cases. So the kids won't be bringing it home from school. But talk about why it might be important as it relates to this pandemic.
Well, we encourage folks, one, for any of your childhood vaccines to make sure, even if your kids aren't in school, to make sure they're up to date. Because at some point in the near future, we hope to get kids back in school and they're going to have to meet those requirements. So we encourage parents with their children at home, even if they're not in school, to make sure that they're up to date on those vaccines, including the flu shot. It's important to get the flu shot because, again, as we've talked about in previous questions, is that it's flu season and you can come into contact with the flu in different venues as well. And so it's important to adhere to those guidelines. But we are really, really pushing it this year because we know that historically, during a potentially bad flu season, we could have lots of folks in the hospital, taking up potential hospital space that could be needed for COVID patients, but also there's a whole host of other things that would land you in the hospital. And we want to make sure that we've done everything we can to keep those spaces open to take care of folks in general, but in particular, if we are to see a continued surge in COVID cases.
Dr. Branch?
For COVID-19 and the flu, it's here, it's real, and they both are potentially deadly. And the one thing you do not want to do is have them both simultaneously. That can be a recipe for disaster. And so it's important, get your flu shot, period.
Dr. Branch, you have personal experience with the coronavirus. you caught it, you recovered at home, I believe. What did you learn from that experience that other people can benefit from?
Well, clearly it's real. I got it. I was very ill. I was sick. I had a cough. I had a fever. I had a little chills type of a thing, but I lost my voice. And it's real. Now, I was blessed. I was blessed in that I did not require any type of oxygenation. I did not require to go to the hospital or anything like that at all. So I came through after having what most people would consider the flu. But I can say to you the fact that we don't know where it is. COVID-19 is ubiquitous. It's everywhere. And although I was really trying to be very, very responsible with the whole 3 W's, I still caught the COVID. And so one of the things I thought was very, very good, and the one thing I had done is as soon as I became symptomatic, I quarantined myself from my family. And I am glad to say that up until this day, no one else in my household got COVID-19. And that's something that really worried me and I was extraordinarily concerned about. You don't want to give someone that you love a potentially deadly disease. And unfortunately, that's what happens. We're getting it a lot of times from our loved ones.
For someone who does have it, when should they go and seek more medical attention, go to a hospital, for instance, or should they just stay at home and tough it out?
So what really happens, and right now I tell folks, if you do have COVID, I actually always say go and get what we call a pulse oximeter. And that is a little apparatus. It's about $15 to $22, and it measures the amount of oxygenation in your blood. And I tell folks, get that, wear that, use that multiple times a day, just to make sure that your oxygenation, which is supposed to be around 97% to 100%, if that's dipping and dropping below 94, 93%, you should then be calling your doctor and considering going to the doctor. Also, you take the Tylenol and the Motrin, right, for your fevers and all those other types of symptoms that you have. If you are taking Tylenol around the clock and you're taking that Motrin around the clock, and your fevers are really catching above 102, I think you're going to have to probably go and see a doctor. So I think that just like if you had the flu, and you're going to be feeling bad, but if you are not getting any better, and this is getting worse, and you are becoming short of breath, chest pains, or any other type of symptoms like that, you need to seek additional help.
Dr. Gales, I don't know if you want to add to that, but before we go, I did want to raise the topic of mental health in this holiday season. It's winter, it's dark, the days are short. We're all a little bit social to different degrees and want to see people over the holidays. What's your advice for keeping everything in balance as we get through the next stage until we have a wide use of a vaccine?
Well, it's important to stay connected, but to be very careful and cautious about how we connect. There's a lot of different platforms that allow us to still be able to connect with our friends and our family, whether it's through a virtual sense, kind of like we're doing this interview here. But, to really think very carefully and seriously about the potential impact if we do get together in person. There's different sayings out there that saying, quarantine for the holidays this year so that we can be alive to be in place to celebrate together next year. And so, thinking outside the box and taking advantage of some of those alternative mechanisms to connect, because again, it is important to connect and stay connected with your support group and your network. But yeah, just be very careful and think very carefully about the potential impact of in-person interaction.
Doctors, we appreciate your time. Happy holidays. Thank you very much.
Thank you. Stay safe.
Now that a COVID vaccine is being approved, the new challenge is getting it to the people who need it most.
I'm excited. I am. And I'm excited for my parents because I think they'll be some of the first people to get it.
For some, the COVID-19 vaccine comes with hope for better days ahead.
I am a little bit worried about, side effects and things like that and long-term side effects, but I think, the good will outweigh the bad.
But not everyone will be rushing to get vaccinated.
I know there was urgency to get one done, to get it created, but I'll wait for a few revisions before I stand in line to get mine.
If we can have more than 70% of the local population immunized through vaccination, I think that then we can start talking about opening up society safely.
Dr. Wilbur Chen is a professor of medicine at the University of Maryland School of Medicine.
I've been pleasantly surprised that we've been able to go this fast. But also I can assure the public that we have not been skipping over safety procedures.
Consensus among experts is that first priority should be given to healthcare workers and workers in essential industries, people 65 and older, and people with certain medical conditions. Dr. Chen says you can expect the vaccine won't be widely available until next spring or summer, when more vaccines from several companies are expected to be approved.
Don't want it to be where the public feels like they're in the candy store and they only want the yellow stripy lollipop, and they pick and choose. I think it's basically the attitude should be first opportunity to get vaccinated, whatever vaccine that is made available at that time should be the one that's received.
Talks about the distribution plan also include discussions about equity.
We know we're dealing with a population that not only has been disproportionately impacted by COVID, but also economically impacted.
George Escobar is the chief of programs with CASA Maryland. He is also a volunteer in a Moderna vaccine phase 3 trial.
They've actually moved their laboratory, parts of their laboratory functions to our main office in Langley Park, Maryland, right? Which is the community that has been the hardest hit with the highest number of positives in the entire state.
That move and his participation helped recruit other Latinos in the area to the vaccine trial.
I wanted to be able to speak truth to my community members, to our members, and also, be able to provide a firsthand experience of what it's like. Not only are we being disproportionately impacted, but we want to be disproportionately represented in these trials to make sure, as a step, to show our community's commitment to try to find a solution.
For more on the path forward for vaccines, we spoke with Daniel Solman, a professor at the Johns Hopkins Bloomberg School of Public Health and director of the Institute for Vaccine Safety.
It's really remarkable. It's been a tremendous effort. And the Operation Warp Speed has both shown how fast we can develop a vaccine, but it also causes some problems because people hear really fast and how could it be and is it safe? And a lot of things have led to this being developed so quickly. One is that it's based on technology that a decade has been invested into. And one of the real big strengths of this technology is that one can quickly make a vaccine. And that's what we're seeing. We also saw tremendous resources poured into the clinical trials, and something that is almost never done, which is the companies started making the vaccine and developing the manufacturing capacity prior to phase 3 trial results. And that's why if we get emergency use, we'll also have vaccine available almost immediately. And that hasn't happened since the polio vaccine in the 1950s. So that's a big financial risk, but not a health risk. So it's really remarkable. And the reports of 90 to 95% effective is fantastic. If that's in fact what we see, it could have a tremendous impact on the pandemic. With all that said, people need to get the vaccine. And a vaccine doesn't save lives. If we have hundreds of millions of doses that are stored properly in cold storage, but nobody gets it, it won't have an impact. We need people to get the vaccine, presuming that it's very safe and effective. It's vaccination that saves lives. And we need widespread vaccination here to really curb this pandemic and go back to our normal social and economic life.
The obstacle to that is what the public health industry refers to as vaccine hesitancy.
I mean, vaccine hesitancy is a commonly used word, and we've seen it around childhood vaccines We see it around flu vaccine, and it's really complicated, and it's context specific, and it's disease specific, and it's vaccine specific, and it changes over time. And what we see now is that a fairly large proportion of people aren't sure they want the vaccine. And in fact, some of the populations that are at greatest risk of COVID disease and mortality, populations of color, are seemingly less interested in the vaccine. So that's a real challenge. But with that said, we've been doing community meetings and we're hearing from a lot of people, they haven't made up their mind. They still want more information. They want to know what the vaccine looks like. So I think the opportunity is there through good education and conversation from trusted sources that we could get there.
Some people are suspicious of the government. Some people, particularly in certain minority communities, are suspicious of the medical profession, given some history there. Do the communication strategies need to be tailored to specific audiences?
They do. I mean, a lot of people distrust the government, and trust in the government has only been going down. And polarized. We see two very different views of the world. And unfortunately, trust in public health authorities has also been hurt by the COVID response. So there, and as you point out, there's a history of medical and research problems in some vulnerable populations. So we're prioritizing people of color because they're at increased risk of disease and mortality. So that prioritization is based on epidemiology and a desire to help them. But what we see as prioritizing for reasons of beneficence, they may view in the context of their history and be even less trusting. So as you point out, we need to tailor messages, not just to the ethnic group or to the age of the person, but to what they think, to who they are. And that tailoring really needs to be able to hear people and then respond in a meaningful way. And as you also point out, coming from sources that are trustworthy.
And I don't want to sound critical of that. I mean, this is coming from somebody who, whenever there's a Windows upgrade or an iOS upgrade, I want to be the last person to install it and avoid any initial adverse effects. The good thing here is that, as you said, all of these have been tested on large groups of people. The chance of an adverse event, maybe we get something affecting one of the vaccines. What would you expect?
Well, it's very hard to predict. I mean, randomized controlled trials, and these have gone through fairly large trials, will give you a fairly high level of confidence that the benefits outweigh the risks for the populations that have been studied. And these large clinical trials are really, really quite powerful. But you don't know everything through clinical trials. If something is rare or it happens in a subpopulation at a rare level, we need to study the vaccine once it's been rolled out. And that's exactly what will happen.
The other thing is for this to be successful and effectively end the pandemic, you don't need actually 100% of the population to get the vaccine, do you?
Well, the estimate is that we need 60 to 70% of people to be immune in order to really curb that pandemic. But one needs to be a bit careful. That's not an average of 60 or 70% across the country or even within a state, but you really need to look at local communities. There needs to be consistent coverage, or pockets of low vaccine uptake will result in reoccurring outbreaks. And we see that with measles, we've seen it with pertussis and other diseases. So that's really what we're looking at here. We're looking at 60, 70% vaccine coverage homogeneously across the population.
Do you agree that the first people in line ought to be frontline health workers and maybe folks living in nursing homes?
So those are the recommendations that have come out of CDC's Advisory Committee on Immunization Practice. And I do agree, they're at very high risk of contracting disease and spreading disease among healthcare workers. They're also a population that is particularly important for our response to COVID. And we've seen really high mortality rates when COVID gets into nursing facilities. So yeah, it makes a lot of sense.
What are the barriers to eradicating this on a global level? So it becomes a different challenge in different countries, depending. Some of these vaccines require very precise, very difficult cold storage protocols to go beyond the United States and effectively end this worldwide. What do we need to do?
Well, if you're talking about eradication, that means getting rid of it altogether. And that is, I am a dreamer. And this is a dream I wouldn't even consider for a long time.
Our thanks to Daniel Solman of the Johns Hopkins Bloomberg School of Public Health. One difference between the initial appearance of the virus and now is the general availability of testing for the disease. Sue Copen has more.
Dave Vatz, Towson University's Director of Athletic Media Relations, is only too familiar with testing for COVID-19.
I am a Tier 1 employee for the Towson University men's basketball team, and so we are tested 3 times a week per university and NCAA guidelines to make sure we stay as safe as possible with the basketball team.
So far, Vatz has been negative all but one time.
I got a positive test back in September, where they actually called me for that one. But that was actually 10 days after the fact.
Vatz, who had been asymptomatic, was given the okay to return to work. For Montgomery County resident Seth Mayman, his test about a week before Thanksgiving went well. His results? Well, he was still waiting to hear the date before Thanksgiving.
This really isn't good that 6 days later I don't have test results. And, you know, that's kind of useless already, as we all know. If you don't get your test results, if I actually had COVID, it would be too late to do anything.
Mayman says he never did get notified. He tracked down the information on his own. He was negative.
The labs are trying to speed up the process of notification because you're right. If you go longer than about a week in terms of being notified, usually your symptoms have improved by that time, and usually the most infectious period is behind you.
Despite the problems, Dr. Gigi Quick-Granville with the Johns Hopkins Center for Health Security says the more testing, the better.
There is a measure of what they call test positivity rate. And what that is how many tests you're getting, how many positives you get. But if it's low, then that's an indicator that you are doing so much testing that you're getting lots of asymptomatic people and people who do not have infection. If it's high, and there are some places in this country that are well over 50% in their test positivity rates, then that's an indicator that you're only testing the sickest people, the people who come into the hospital who have symptoms, and you're not getting a true picture.
There are 2 primary COVID tests right now. One, a rapid test with quick same-day results, and a second test where it can take up to several days to get results. How to choose? If you're having symptoms, go with the rapid test.
They tend to be most useful when somebody's acutely ill and you don't know whether the illness is due to the flu or to COVID-19 or something else. And in that setting, a rapid test can give you a very good indication in a relatively short period of time.
No symptoms? Then the second test is probably the way to go.
As we know, COVID symptoms can be very minor or they can be even non-existent. And for those folks, the PCR test, which takes longer to do, is more sensitive and it's the confirmatory test that we use in the setting of outbreaks in nursing homes or in diagnostic purposes.
There are more than 200 COVID test sites around the state. You can find one near you by going to the state's COVID website and entering your zip code. It's likely mass testing associated with COVID-19 won't end anytime soon.
I suspect that, as we learn more, it'll be, we'll have, more demands and different demands on testing, but I don't think we're going to be out of the testing business for some time.
I'm Sue Copen for Direct Connection.
Sue, thank you. With us now is Dr. Letitia DeRosa, the Health Commissioner for Baltimore City. Doctor, we appreciate your time. I have a lot of questions about testing, but one important thing to point out, I think, is that this isn't the kind of medical test where you need a doctor's order. You don't need a prescription. You can just show up. Is that right?
That is correct. Jeff, again, thanks for having me on the show. It's definitely, we've seen an evolution since when testing first began. So it is more open.
What should people know about who should get tested?
Yeah, so in alignment with the Maryland Department of Health's recommendation, anytime you're symptomatic, you should consider getting tested. If you suspect that you've been exposed to someone, including someone who may not have symptoms, but maybe they tell you a couple days later that they've tested positive, you should get tested. If you're a person who's perhaps at risk because of your occupation, maybe you work in healthcare, or food or grocery, and you're around a large number of individuals, or if you've been to a large gathering, or if you've traveled recently, all of these things would warrant you to get tested.
Is it okay to get tested if you're merely doing it to add another margin of safety for the holidays? That you're pretty sure you haven't been exposed, but maybe you're gonna see some people, and you want to make sure that you're not carrying this.
Yeah, we're absolutely seeing people do that. I think a number of people did that ahead of Thanksgiving. I think if you're going to do that, what's also important to note is that you should have some period of quarantine before that travel, right? So, you get that negative test, but that doesn't then give you the freedom to go out and about. It really is saying, okay, I've got my negative test. I still need to quarantine ahead of traveling and being around other people outside of my household.
And the quarantine recommendations from the CDC have changed. They're not talking about the blanket 14 days anymore.
They aren't. And what I'll say about that is certainly 14 days still remains the gold standard, right? So that's still the period with which your risk is the least if you do go the entire 14-day period. But you're right, they have released standards now that you can do 7 days with testing and 10 days if asymptomatic. So yes, things have changed.
Types of tests. I don't know what you're offering or what is being offered in Baltimore City at the moment, but to the extent people have a choice, what should they be looking for?
The majority of our testing locations are still doing what's called the PCR test, which is the send out, which usually takes, anywhere from 1 to 4 days to come back. That still also remains the gold standard of testing. But there are also some locations that are doing the rapid test or the antigen test, which, comes back in 30 minutes to an hour or so. That test we know can be a little bit less accurate if you're not experiencing symptoms. And so usually we want to accompany that rapid test with the send out test just to be sure.
Then there's the antibody test, which does require going to a medical lab, right?
Yeah, the antibody test is another one. And the antibody test really just indicates a previous exposure to COVID, right? It may not necessarily indicate active infection.
What about the cost? Is that something people should be worried about? Will their insurance be billed for it? How does it work in your jurisdiction?
Cost is it's still free here in Maryland. So, the majority of testing locations, perhaps if you go through your doctor's office and they perform some level of service, but if you can go to a convention center, you can go to any of the state supported and city supported testing sites, and the cost is free.
I had a relative who early on in this crisis had a test, and the result came back, I think, 16 days later, which, kind of a moot point after that. I think it's much better now.
It is.
But, with another crunch coming, possibly for the holidays, what's reasonable to expect?
So I think, again, that 2 to 4 days is still the window that we're seeing. It's the window that we saw also around Thanksgiving. So, ideally it's less than 48 hours so you can make decisions. But, I would say anywhere from between 2 to 4 days.
What happens if somebody comes back positive? First question, is that 100% mean that you have it? And flip side, does a negative 100% mean that you don't have it? But what happens at that point in terms of any advice you provide and any contact tracing that kicks in?
The second we get a positive test, we work with the state contact tracing team. So if that person is a Baltimore City resident, they'll either be contacted by the state or they'll be contacted by city staff to do the contact tracing interview, right? So that is us trying to understand what potential exposures they had during the time when they could have spread disease. So who else may they have infected, as well as where was perhaps the source of their infection. So that's typically the trigger for us to start that process.
What do you take away from the daily data download that the positivity rate is 8% or whatever it means, whatever the number is, what does that mean to you on a day-to-day, week-to-week basis?
What we're seeing is the number of cases are increasing significantly. And, we're seeing that, yes, there's a lot more testing, but even with a lot more testing, we're seeing a lot more people become positive because there is widespread community transmission. And so we have to remain ever vigilant anytime we're leaving the house and around individuals not in our household. I think the other thing that we're really looking at and paying attention to now is what we're seeing happen at our hospitals. So as a result of this influx of cases, we're now seeing hospital utilization, climb very quickly to where we were back in April when we had that initial spike in cases.
Just to use rough numbers, if 10% of people who get a test turn out to be positive, that means for the people working at the testing center that every 10th person they see has, this disease. They're a potential threat, not only to the people working there, to everybody else in line. What do you do in the testing operations that you've run to try to maintain a level of safety for your people and everybody there?
So it's extremely important that we provide our staff with PPE, so appropriate PPE, and understanding of infection prevention protocols. And so, much of our staff at the sites are clinical, and so they're well versed in the necessary measures to avoid potential exposures. But that provision of PPE and understanding what the process is in the event of exposure is extremely important to our staff.
PPE, personal protective equipment, and how's the supply been lately?
The supply has been much better. I mean, especially compared to where we were in the beginning, that we have PPE supply stored up, as do our healthcare partners.
People who may have seen news stories on the testing in the beginning probably have seared into their minds an image of an extremely long Q-tip, basically a very long stick. That went up the nose of the person being tested. I've not personally been tested, but I hear from people who have that it's much less intimidating these days, and the swab is really not a big deal.
Yeah, I think it's reasonable to anticipate some discomfort, but yes, we are not aiming to make it unpleasant, but it is, it can be uncomfortable for sure.
Best places to get information on this. Statewide, the coronavirus.maryland.gov website has a lot of data, a lot of resources, but also gives you testing locations. If somebody is looking for a test in Baltimore specifically, where might they look?
Absolutely. Coronavirus.baltimorecity.gov also provides that information for the city.
And before we go, just heading into the holidays, how are you feeling about things? This has been a tough year for people in your profession, people who've had the disease, maybe lost jobs because of it. You feeling optimistic, or are you feeling a little concerned about the short term?
I think this is going to be a challenging time for many of the reasons that you mentioned. There are many who've lost loved ones. There are many who've lost their livelihood even as a result of the pandemic. And so I think in times like this, as much as we can support each other virtually or socially distance, I think now is a time to pull together and do that. And I think to continue to really support our healthcare workers that are working on the front line. They've been working this response now for a number of months, and I think many of them are exhausted and tired as well, yet find the strength to keep going each day.
Letitia Duraza, the Baltimore Health Commissioner. Doctor, we appreciate your time. Thank you. COVID-19 has had a disproportionate impact in communities of color, as our Charles Robinson reports.
I lost my dad. And the way in which I lost him was so, unacceptable, but unexpected. Dad was in a senior citizen building. And so it wasn't just about the virus. It was about the lack of regulations. It was about the disregard for life.
Stacy Smith's dad left this world on April the 27th. COVID-19 has wreaked havoc across the state, according to health professionals and the Maryland COVID-19 website. Hundreds more Black Marylanders have died than would have been expected based on African Americans' share of the state's population.
is we are already disproportionately impacted by our health disparities. So when we talk about pre-existing conditions, diabetes, cardiovascular disease, all those things are disproportionately present in the communities of color. So I think for these reasons, and probably more, we have been disproportionately impacted by the virus.
Earning community acceptance of a new vaccine in these communities will be a challenge.
And when you mention injecting genetic information into someone's body, people have an extreme fear reaction, given the history, not only of Black people in general with the medical system, but specifically here in Baltimore.
The inherent presence of distrust around vaccinations and the medical system. So I think we have a historical context that we have to manage, a logistical context that we have to manage, and then a general sort of disconnect or not strong relationships and ties with medical communities.
We really become the testing sample, if you will. And I'm not willing to jeopardize my health or any more of my family's members as a result of this new vaccine.
I want to talk about the 50,000 foot view. Obviously, this pandemic has changed our thinking on both healthcare and public healthcare.
I hope that we will see a restructuring of what public health means and looks like, for one thing, in the United States. And then the second thing is I hope that the vulnerabilities that have been identified in that infrastructure get shored up for the long term.
COVID has unearthed flaws in our medical system for which there may not be a quick cure. In Baltimore, I'm Charles Robinson for Direct Connection.
And joining us now is Dr. Sharita Hill Golden, the Chief Diversity Officer for Johns Hopkins Medicine. Dr. Golden, it's nice to see you again.
Nice to see you too. Thanks for having me again.
When we talk about disparities, it's a complicated problem, but it's a really simple number. The Census Bureau says that the population of Maryland is 31% African American, but the state health department says when you dig into the numbers that the percentage of people who have died of the coronavirus is 38 or 39%. How do you think about this problem?
Well, I think what those figures point out is that when we think about the disproportionate number of deaths, it's really highlighted in the figures that you just mentioned, that the percentage of deaths are even higher than the proportion of, African Americans, for example, who are in the state of Maryland. So it's out of proportion to the size of the population. And I think, when we were speaking last, we talked about the contributors to those disparities. Some of those things are related to the health system experiences and the medical and scientific experiences. So there's been distrust in the medical establishment because of historical practices of experimenting on slaves and other minoritized groups. And then, of course, like the Tuskegee syphilis experiment, when treatment for syphilis was withheld in African American men to learn the natural history of syphilis. So many communities still remember that. And then there was the eugenics theory that purported that there were certain groups that were biologically inferior to others. And we know today that that has no scientific foundation, but unfortunately, some of our clinicians may still perceive certain populations to be less intelligent, less likely to follow care recommendations. So there can be a biased experience in the healthcare system.
And there's so many other things. I mean, there's the general access to quality care, the number of people from minority backgrounds who are in the healthcare profession. You get into people who maybe work more often in public-facing jobs, maybe ride public transport more often, have multi-generational learning, living arrangements, thinking about urban pollution and higher asthma rates. It's a long list.
It definitely is. So what you've just outlined are what we traditionally call the social determinants of health. And so these are conditions in which people live that influence their health as well as their healthcare access. So, one, of course, is healthcare access. And then once you access the system, we talked a bit about what contributes to maybe that inequitable quality of care. But then, poor housing conditions that resulted from historical practices of redlining and lack of economic investment in neighborhoods really has resulted now in spaces where not only is there housing instability, but there's a lack of green spaces and parks for exercise. And then there's also a lack of healthy food access. So all of these things increase the risk of chronic diseases. And then of course, there are the increased risk of COVID exposure from social determinants of health. So if you have transportation challenges, as you mentioned, and you have to ride public transportation, you're more likely to be exposed to COVID. And we know that racial and ethnic minorities are more likely to be in jobs that require them to be on the front lines and essential, but then they may also be less likely to have the transportation to get there, so they're relying on public transportation. So that just created a perfect storm. You know, the same social conditions that contributed to disparities in chronic health conditions also contributed to disparities in COVID. And so, you know, this is sort of the perfect storm that's been created, unfortunately.
If there's any good news, I mean, there's wide awareness of the problem now, and maybe an opportunity to do something from a short-term perspective, long-term perspective. What do we need to do?
I think, you know, there's two things. So one of the things that I work on in my current role, of course, are the things within the health system. So how can we, make sure that not only do we have unconscious bias training for our providers, which to me is just scratching the surface, but then to make sure they understand the manifestations of structural racism, how that manifests in healthcare and government and education and housing, because all of those things impact health. And then how can we make sure in our healthcare system that we're implementing the class standards, which are the culturally and linguistically appropriate standards. So making sure there's interpretation services, translation services, all of our education is literacy adapted. And then there's the making sure that our workforce, our biomedical workforce, is diverse. And so that's another big area that my office focuses on, is workforce and our diversity in our physician workforce, our nursing workforce, anyone who touches the patient, because that is ultimately going to result in those life-changing decisions. I say that diversity and inclusion in healthcare is a matter of life and death, because our biased decisions can ultimately harm a patient. And so that's why we need to have a diverse workforce to address that.
It seems like at our taping time, it's likely that a COVID-19 vaccine is going to become available to the general public in the early part of next year. Ensuring access to the vaccine within minority communities and addressing some of the things you talked about with the experimentation that has left a longstanding, bad taste among people of color. How do you overcome that? What are you thinking about in terms of trying to ensure that there's equal access to the vaccine and equal uptake of the vaccine?
Right. So those are probably the hardest barriers that we have to overcome, and, really sort of bending the curve of the pandemic again and hopefully ending it. And so there are two vaccines that one is being evaluated by the FDA tomorrow. They will make a decision on whether they will issue an emergency use authorization, and then the second vaccine next week. So, we're really sort of days away in a lot of senses. And so what's really important, I think, first is to acknowledge that we understand why it is that you are distrustful or uncomfortable with the medical establishment. But at the same time, it's the same community that is disproportionately dying from COVID-19. I doubt that there's an African American in Maryland at this point who doesn't know someone that's had or died from COVID. And so in that context, then we have to really make sure that the community is properly educated, that the myths are dispelled. One of the concerns I've heard is that this is a new technology and it hasn't been used before. The technology is the first time we're using it in a pandemic caused by coronavirus, because this is the first time that's come up, but that technology has been developed over about 9 to 10 years. And in fact, the scientist that's been leading the group at NIH overseeing that technology development is an African-American scientist, Dr. Kizzmekia Corbett. So I think these are all important things for our community to know so that they can make informed decisions, and have an opportunity to ask questions. So we'll be partnering with our trusted community messengers, often the faith community, the civic partners, to really help us in that messaging and education for the community.
Your role at Johns Hopkins, one of the world's great medical institutions, located both campuses in communities in East Baltimore that have a lot of challenges. To what degree does your work focus inside of the institutions, and how much is focused outside?
Well, it's an interesting question because the majority of our office, we're the Office of Diversity, Inclusion, and Health Equity. So we're very focused on our internal work. So we want to make sure that not only is our workforce diverse, but that it is inclusive, that people can bring their full selves to work. Because when we have a really inclusive and rich environment, we can give the best care to our patients. And we focus on the health equity operations. But, I would say that at least my faculty appointment is in the Department of Medicine, and at least 25% of our staff live in the zip codes around Johns Hopkins Hospital and Johns Hopkins Bayview Medical Center. So in fact, our community is working with us inside of our walls. And so really what's particularly important is that we've got to make sure that they feel engaged and well respected within our walls, and then they can be our ambassadors outside in the community. So I think that's an important piece. But the other external piece that my office focuses on is that we partner a lot with our government and community affairs office. And so, we're very much concerned with supporting advocacy efforts at the state level to address some of the social determinants of health that we talked about earlier. So, legislation to really address affordable housing, healthy access to food, all of those things that are truly impacting health. And so we've been partnering with colleagues and allies in the Maryland legislature. And I know in the January session, they will introduce some health disparities legislation. So that's sort of the outward facing role that my office has as well.
Dr. Sharita Hill Golden joining us from Johns Hopkins. Doctor, nice to see you. Appreciate the time.
Thank you. Thanks for having me again.
Where can you find current, accurate information? Well, here are some tips and resources. And that is Direct Connection for this week. Remember to follow us on Twitter and Facebook at MPT News. Now for Charles, Sue, Nancy, and all of us at MPT, thank you for watching, and we hope you have a safe and happy holiday season. Good night.
This program was made by MPT to serve all of our diverse communities.
Programs on MPT are made possible by our members and the following.
Frederick County's fleet of all-electric buses save the county on fuel costs and drastically cut down on emissions. Learn how to become a Maryland Smart Energy community at energy.maryland.gov. Global Medical and Health Services, LLC, a residential service agency, has been a community-based healthcare staff agency as well as a skilled nursing and physical therapy provider for adults and medically fragile children since 2006. Visit globalmedicalhealthservicesmd.com.